Hi, good evening, everyone. So today's this talk is about understanding basic statistics when we look at multiple trials. It's about net number to treat, as it is mentioned. This is an important topic because this goes on to tell you what is the efficacy of a therapy vis-a-vis, say, other therapies. Because this tells you what number of patients you need to treat to achieve one event reduction over what period of time. And hence, you may have multiple trials coming in for multiple therapies, for multiple options, for multiple indications. But when you have to weigh out between the therapies to assess as to what was the care that resulted into what impact in the outcomes, you need to look at a number called net number to treat or number needed to treat. So this basically will discuss today in this talk. Um, Basically, before I jump on to that, let me take you to two important concepts. One is IE and IU. IE is the probability of seeing no improvement after receiving the therapy. So this is the inverse of probability of seeing the improvement. So this measure applies only to a treated group. So when you have a treated group, you look at IE and you see if what would be the outcome not improving, the probability that you find on it. And IU is also referred as a probability of seeing no improvement after receiving the control therapy. And based on this, then you amplify and look at the net number to treat. So this measures applies only to control group, the IU, and the control group may receive a placebo treatment and or the standard care, as we know, on top of the existing new treatment. And this is what you get as the probability outcome in IU. So the meaning of net number to treat or number needed to treat is dependent whether the control group received a placebo treatment or an existing treatment, that is the standard care versus placebo care. And in case where placebo is given, the net number to treat is also affected by the quality of placebo. For example, sham procedures, as we know in renal denervation therapy, when patients were taken inside cath lab and they were not delivered renal denervation therapy, but they had a sham procedure, a procedure patient who did not know they actually underwent a procedure or not, there was a good amount of reduction in the blood pressure in this renal denervation subgroup, despite actually not getting denervation therapy. It's just a sham procedure the patients were undergoing in the control group. So the type of placebo, for example, injectables versus oral therapies would also have different outcomes in terms of the impact of the placebo. Now, these are some formulas that I thought I'll talk about before I jump on to number needed to treat. We all have a very simple table, and there will be some more talks that people will tell you about the odds ratio, etc. But I'm just going to summarize all of them in brief. You can see there are two groups. When we take a study, you'll have an experimental group and a control group. So let's assume that the experimental group or the therapy group, which has been receiving the new therapy, is of say 150 patients, while the control group is of 250 patients. Now assume that out of 150 patients, there are 15 events, say death, if you're looking at that as an important indicator. So say, assuming that there are 15 events in the experimental group, and out of 250 of the control group, the patients receiving only the placebo or the standard care, there are 100 events. Now, this goes on to tell you the event rates. Now, event rate would be just the ratio of the number of events out of total subjects. So in the experimental group, it will be 10%, while in control group, it is 40%. Or if you define it in decimals, it will be 0.1 and 0.4. Now, what is the absolute risk reduction? It is representing the difference between the two event rates. So we have 40% in control group event rate, 10% of in experimental group rate. So the difference between the two is 30%. So 40% in control, 10% in experimental. Hence, the absolute risk reduction is 30%. Now, relative risk reduction is the percentage change from the baseline. Now, if you look compared to say 0.4, there is a reduction to 0.1 is about 75% reduction. So 75% reduction has taken place from 40% to 10%. And relative risk reduction looks though very huge, but absolute risk reduction is only 30%. Now, net number to treat is arrived at as by 1 upon absolute risk reduction. 1 upon absolute risk reduction. So then if that would be assessing as to how many patients do you treat to prevent one event. Now, absolute risk reduction is 30% reduction is achieved in every patient. So in how many patients you need to treat so that there is one event prevented. So one event is prevented. So if 1% is person, in every person, the risk reduces by 30%. It will become 1 or 100% when the number of patients needed to be treated is 1 upon absolute risk reduction, which is 1 upon 30%, and multiplied by 100, you will get it 3.33. So you need to treat 3.33 patients to reduce one event. Now, this is important to define as to what you're looking at. So risk ratio and odds ratio are different things. Risk ratio is again the ratio between the EER upon CER. So EER is the event rate in the experimental group, and CER is the control event rate. And then you divide the two is the risk ratio. So here you have 0.25. When odds ratio is, of course, AD by BC as we call it. So odds ratio is the EE by EN upon CE by CN, which is the events in experimental group upon events, non-events in experimental group divided by control events and the control non-events. And this odds ratio is here 0.67. So, and there is another factor called as preventable fraction among the unexposed, which I am not talking today. So one of the examples I will try to give you so that you can understand how to comprehend this. Real life example, say, would be the Escort LLA trial. So this is the trial where the atorvastatin 10 milligrams was started in patients on hypertension, but no previous CV disease. So this trial ran for 3.3 years. And during this period, the primary event, which was defined as a new onset of MI, new onset of heart attack, not death, new heart attack was reduced by 36% in a relative risk. Now, what does it mean? Now, if you look at 36% overall risk reduction here, that this difference was, though relative, absolute difference between the two arms was not this much. It was the event rate of MI in the patients not receiving atorvastatin on Escort LLA trial was 2.67%. While in treatment arm, it was 1.65% in the patients who received atorvastatin and had hypertension. So the MI rate between the two groups over a period of 3.3 years, the difference was only 1.02%, which is nothing but the difference between the absolute risk between the two groups. That is 2.67 minus 1.65. So the absolute risk reduction is 1.02% over 3.3 years to prevent one MI, one myocardial infarction, one heart attack. So to get the net number to treat, you will divide 1 upon 1.02 multiplied by 100, which would turn out to be 98.04, almost 100 because 1%, right? So you need to treat 98.04 patients with atorvastatin 10 milligrams for 3.3 years to prevent one heart attack in patients with hypertension with no history of previous CV disease. That is how you interpret Escort LLA trial. So every trial, when they come up with a number, you look at the number of patients. So you have to prescribe atorvastatin to a patient with hypertension but no CV disease for 3.3 years. Once you prescribe it to 98 patients, you will have prevented one myocardial infarction. That's how you interpret net number to treat. Thank you.